Okay, we have been submitted a plan today for evaluation of site number 4 in what is a very common situation that needs for implants. Um, this particular case was planned with two different plans. Both were pretty good. So I decided to make a little change from my routine this time. Instead of critiquing the plan that was there, what I want to do is start from scratch and make my own plan for this site. So if we get a little history on this particular tooth, what we'll see here is that it is a post-core treated tooth number 4, where the crown and the core has fallen out and the tooth is non-restorable. One of the things that I like to do is go ahead and go through it. Now, just as a quick review here, one of the things that we can see is we can create a PA by just using our angulation tool here to go ahead and get that centered in the root, and then using this angulation tool to get that centered in the root. So now we can get a good idea of what's going on with the tooth. We can see that we have a nice buccal plate, we have a nice lingual plate, we do have some apical area for engagement and extension. So, excuse me, my first evaluation of this is that this is a great site for immediate placement. And I'm basing that judgment on a buccal plate being present, a nice lingual plate being present, relatively healthy and level bone, lack of significant infection on the tooth, and apical area for engagement. So just looking at those things, I'm already making the judgment that we can do a immediate placement. This case was submitted with CEREC data. Um, and looking at the scan, we can see that we have a full arch here. It's well integrated. We have a very well planned restoration here. So that makes everything nice. And then if we look at the data itself, excuse me, the pan itself, what we're able to see here is that this is a good case for an OptiGuide. Tooth number 2, tooth number 6, 7, 8, 9, 10 are good for integration. And as long as we can get good integration with non-metallic restored teeth, circumferential metallic restored teeth, we should be able to do a traditional OptiGuide on this situation. And that's, again, redone here with the CEREC data. So all the things are in place here to be able to do a wonderful job on this case. So let's go ahead, and our plan is very nice here. Everything's seeing here very quite nicely. And let's go ahead and take a look. So what I would like to do is just use my tools here to outline the bone as I see it, just like so. Outline the tissue as we see it. Okay, and then also outline the tooth as we see it. So now once I have all of this outlined as I do here, what I like to do now is go ahead and look. So I'm going to use hash lines in green here to show you all this wonderful area that I had for engagement. And then again, we can see the sinuses way up here. So we got plenty of good bone here. The most difficult part of this will be getting the ideal plan and then being able to take the tooth out atraumatically using periotomes, proximators, and apical retention forceps. Should be no issue with that. So hopefully that helps in understanding what we're looking at there. So now what I'd like to do is go ahead and plan the implant. Site 4, I'm a big believer in the Noble Active, and my original starting point for a premolar of this site is a 4.3 by 13. We'll go ahead and drop the implant in, just like so. I drop it in, and then now I will go through my checklist and get this centered in the bone, just like so. As you can see here, we're hitting the adjacent roots. Go ahead and get that centered pretty well there. And then now we're starting to see a relatively plan starting to come together there. Always keeping the axial view in line there. And we can start to see exactly what we're dealing with here. So the bigger key that I see here is, remember that, let me draw my lines here again, is that this is, it's going to be green this time, bone. So I want 1 millimeter apical, my plan, to the bone. So I'm going to drop my implant about right there. Now, I always plan on the side of being a little bit deep in my plan itself, because I can quite easily back the implant up or not place it all the way if that at time of surgery I find that I am a little too deep. I do not like to plan shallow. I prefer to plan deep and then make the decision at the time of surgery if I want to back it up or not place it all the way down. So based on my plan here, this is pretty much exactly what I would do. Let's check out our sleeve, see where our sleeve would go. And here we can see our sleeve is going to be a little tight here. Okay, this is also a good tool to determine centering of the implant, and also to determine if we have enough space for a quality restoration. So in looking at this view, we can see we're pretty well centered. Maybe we got a little room there. So to be able to do this case, we're going to need to do some adjustments on the interproximal of tooth number 3 and the mesial of 3, and maybe on the distal of tooth number 5 to be able to get the sleeve in there. Alternatively, the choice is to go to a 3.5 millimeter implant, which is certainly not my preference in this particular case. So I would prefer to stick with a 4.3 millimeter implant, and I would go ahead truthfully and make the adjustments to the adjacent teeth. My guess is this tooth may have fell out some time back, and we can see here actually in the axial view, we can see here how that tooth is probably a little over contoured with that restoration. So I would go ahead and probably err on, to be honest with you, err on the side of getting it from the mesial of tooth number 3. So buccolingually, we're pretty well centered. Mesiodistally, what we're looking for are adjacent roots, and we can see here as we use the 360 slider here, we can see that we're plenty of distance away from the adjacent root, and adjacent root there, got plenty of distance there. Vital structures, we're away from roots, we're away from the sinus. We're not into the sinus, how about that? Everything looks fantastic there. Bone level, we are probably just a hair deep in this particular case, but again, we've purposely planned it a little bit deep to allow us to back it up at the time of placement if we don't want it to be that deep. And then our sleeve is in position, requiring us to do some adjustments on the mesial and distal. And then 360 shows us everything to be correct here. So this looks like a fantastic plan with a screw retain restoration. In terms of the lingual plate, how close we are there, not an issue. That's pretty dense right there. It's a good cortical plate. Good cortical plate here on the buccal. Pretty straightforward. I would personally go ahead and add some bone in the extraction site, in the quote-unquote the gap after we take the tooth out. So everything looks pretty good here. My guess would be this would be sized to a 3.0 drill, and then the implant would be placed using the expanding condensing properties of the Noble Active implant. We'll get quite a bit of stability here. If we wanted to, you could even consider going to an 11.5 millimeter implant with no issue whatsoever. So great case, and if we want to compare it to the plans that were sent to me, the only main difference here between the plan that I don't like is the bone level itself. So if we take a look, here is a bone level, and the implant is right at bone level, maybe apical to bone level, sorry, coronal to bone level. So in this particular case, I would just take this plan and probably drop it down a little bit. Other than that, I would change nothing about this particular plan. So if we take a look at that compared to my plan, it's pretty similar. So thank you very much.